All right, we'll get started in just a minute and I will give a brief introduction. But for now, those of you who are joining, feel free to introduce yourselves in the chat. Thank you. Welcome, everybody, and thank you for joining. My name is Grace McAmoyle, and I'm a Senior Research Coordinator for BHIPP. I am going to be introducing our presenters for today and facilitating the Q&A portion at the end of the session. For those of you unfamiliar with BHIPP, I would like to provide some information about our program. Maryland Behavioral Health Integration in Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers and emergency medicine professionals in addressing and managing the mental health concerns of their patients. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, telemental health services, and training and educational opportunities. The BHIPP Warm Line is staffed by a team of child mental health specialists and is available Monday through Friday, 9 a.m. to 5 p.m. Our phone number and website will be placed in the chat for you. It is my pleasure to introduce today's BHIPP webinar, What Pediatric Primary Care Providers Can Do While Patients Await a Formal ASD Diagnosis, presented by Krista Bay and Dr. Antonia Gerard. Krista Bay is a pediatric primary care provider in Baltimore City and part-time faculty member at the Johns Hopkins University School of Nursing. She is currently pursuing her Doctor of Nursing Practice, DNP, degree at Johns Hopkins, where her scholarly project focuses on improving autism education for pediatric primary care nurse practitioners. Dr. Gerard is an assistant professor and licensed psychologist within the Division of Child and Adolescent Psychiatry at the University of Maryland School of Medicine. She graduated from Nova Southeastern University in Fort Lauderdale, Florida in 2014 and completed her postdoctoral fellowship at Mount Washington Pediatric Hospital in Baltimore, Maryland. During her time there, following her fellowship, she developed an early intervention program focusing on psychology's role within multidisciplinary pediatric clinics. She currently conducts psychological evaluations through the Center for Infant Study and BHIPP and supervises Healthy Steps specialists embedded in pediatric primary care and family medicine practices. We are very grateful to have you both here. Thank you so much for sharing your expertise with us during the session. And I'm going to hand it over to Krista. Oh, you're on mute.
Hi, everybody. I'm going to share my screen. Thank you all for attending. No. Sorry. Share screen. Okay.
Oh, I think you're in presenter mode on that side.
Yeah, I got it now. Can you
Okay.
all see just the slide?
Mhm.
Perfect. Thank you very much. I unfortunately only have one screen, so I get to utilize some advanced screen sharing techniques that I've been quickly learning. So thank you all for attending. This is hopefully going to be a session to take with some key takeaways on what we can all do in the primary care office to support families while they're trying to figure out and navigate systems. We're partnering with BHIPP, who's supported by Maryland Department of Health and Behavioral Health Administration in collaboration of University of Maryland School of Medicine, Johns Hopkins University School of Medicine, Salisbury University, and the University of Maryland Eastern Shore. And again, the program is supported by the Health Resources and Services Administration. And I'm very thankful for this program and BHIPP in general. And disclosures, neither one of us have any conflicts of interest, and we are using the pre and post test answers as part of my DNP project research looking at education. today's learning objectives. So by the end of the lesson, hopefully everyone will be able to identify at least one approach or screening for pediatric patients suspected of having autism, describing at least two caregiver resources in the management of pediatric patients, identifying at least five local resources while waiting formal evaluation, and applying the use of resource checklists and management tools while waiting diagnoses. And then while I was starting out my research, the research was very large. And, if any of us who work or have any contact with anyone with autism, there's a lot out there. And so I tried to put a big net and just kept trying to bring it into smaller pieces. But a few quotes that I found that I think is very important to set the tone is that from Grandin, different, not less, by Scott Hamilton, the only disability in life is a bad attitude. And then Kim Stagliano says that autism is not a tragedy, ignorance is the tragedy. And then someone in the autism community used that same quote and kickstarted their own version of it by saying running out of bacon is a tragedy. And so I think that that sets the tone for us because right now, unfortunately, a lot of people are looking at autism as being such a bad thing, and we know that that's not true. And so, really, just trying to help these families navigate that autism can be very empowering and very wonderful. So, I want to bring up the piece of history and the stigma of autism because I think that's very important for us when we're talking to families. And so, in 1943, Leo Kanner at Johns Hopkins published a landmark paper titled Autistic Disturbances of Affective Contact. He describes 11 children who share three key traits: an early onset of symptoms, noticeable difficulties with social and communication skills, and repetitive or restrictive behaviors. And this work became the foundation for what we now recognize as modern autism diagnoses. But Kanner's paper, while it was still groundbreaking, wasn't the true first description of autism. And in fact, decades earlier in the 1920s, a Russian psychiatrist named Dr. Grunya Sukhareva also had already described very similar characteristics in 11 children. But even though her work was remarkably ahead of its time, it went very much unnoticed. And a lot of people believe it's most likely due to her gender, her location in Moscow, and the political tensions that were happening during that time period. But now there's being more light shed on her and her research, and she's now being recognized as one of the true pioneers of autism research. So, unfortunately, though, the early decades also brought a lot of damaging misconceptions. And in 1949, Kanner himself suggested that autism might stem from emotionally cold or distant parenting. And this is where we might hear some of those old theories kind of pop up. And then the idea sort of became amplified by Bruno Bettenheim in the 1960s, who promoted the infamous refrigerator mother theory. And it became a very deeply harmful notion that blame mothers for their children's autism. And then fast forward a little bit later, 1969, Kanner reversed his position, saying that autism was innate and not caused by parenting. But the damage was already done. Psychoanalytic theories continued to circulate for years, and parents, especially mothers, carried the burden of misplaced guilt and stigma. And about 30 years ago, I worked in an autism camp with for autistic people of all ages. And during our orientation process, they had family members come and talk to us about their experiences. And I distinctly still remember to this day a woman in her about 60s sharing with us the experience that she had at her then 40-year-old son who had been diagnosed with autism, and they kept telling her over again it was her fault because she was such a cold person. And she's sobbing, we're all sobbing, and it was just, you could still see the trauma, even though at the time 30 years had passed since she had been told that, how devastating it still was to her. So a turning point came in 64 when Remlin put out a book called Infantile Autism, and he sort of challenged the idea of the cold parenting myth and argued that there's probably more of a biological understanding and that we really need to look at neurological factors. And this work really steered towards science and public perception of looking at more evidence-based and compassionate understanding, which again then started a framework of more media influence, which brought in cats, who then said, hey, I really see this is a real struggle for children and families, and it sort of exposed this false parenting theory of it being more of related of how people are parenting their child, and more of this is possibly a biological perspective. And so the media coverage really played a crucial role in shifting the public awareness towards science and away from blaming the family. But again, we're still seeing traces of that today. There's still a lot of misconceptions that are still being battled. And unfortunately, we can see how powerful and lasting the stigma can be. But it's really important to understand this history. And it's not about just looking back, but about moving forward with our empathy, our accuracy, and our advocacy for every autistic person. And so I want to shift gears and just talk a little bit more about the significance and prevalence and knowing where this data comes from. And so, according to the latest data from the CDC, the prevalence of autism has increased to 1 to 31 individuals. But in contrast, the WHO has a ratio of 1 in 127. And they definitely report a lower global prevalence. And here in Maryland, however, our rates are very comparable to the national average. So, how are these numbers determined? Well, in the US, each state contributes data through designated reporting sites. And in the graph below, you'll see the highlighted areas of our tracking sites in Maryland. However, it's important to note that not all states are equally represented in the data. And globally, there's a significant underrepresentation from low and middle income countries. And so these regions are often lack the resources for widespread screening or adequate support for individuals with autism. And I don't know if any of you have experienced this in your practice, but I have had families who have, migrated and have come over to our country and become citizens, and they may have spent their early childhood years in their country, but may not have had a lot of access to primary care or even understanding. And so just trying to help them navigate the system and understanding what is going on with their child, and how to help them best with the services we have here. Also, just to put in a plug for the WHO, they have a very wonderful autism toolkit that is targeting to low and middle income countries to help them be best served to support families. And then the CDC and Maryland Department of Health data show that Black, Asian, Pacific Islanders, and Hispanic and multiracial children are more likely to be identified with autism than white children. So we know it can affect anyone. We know it's a very complex interplay of genetic and environmental factors, but we also know that even if children who are Black, Asian, Pacific Islander, Hispanic, and multiracial are more likely to have it, we also know that conversely, they're less likely to receive services. So that's really important, especially in some of these urban areas where we're really trying to help support the families. And so to piggyback on the impact on families, the financial impact is that with families who have children with autism, have a 40 to 45% higher cost, and that includes medical costs, than children without the autism diagnosis. Familial stress is often reported, including underemployment, higher rates of divorce in households with an autism diagnosis than without. Often mothers report fatigue and depressive symptoms. The families will usually need time off for appointments, and they typically are going to try to spend time with other children in the household, and so often they'll feel very pulled in different directions. And social isolation. Many families struggle with finding support or activities to do with all the family members together, as well as friendships that might have common experiences, and that can be very difficult for families. And so I'm just going to throw a question out there to all of you. What do you think is the biggest challenge when encountering developmental concerns or delay in your practice? And if you can put any sort of response in the chat, that would really be appreciated, and we'll just take a minute for you to share.
Okay, I'm seeing someone saying time as a challenge. A repeat of time being a big challenge. Finding resources for families that take insurance, having a hard time finding a specialist who can see them in a timely fashion, finding resources to help, lack of local resources, community, reimbursement, parents in denial at the beginning, appropriate resources. Again, resources being a big one. Yeah.
Well, that's exactly what hopefully we're going to be talking about. And again, oops, wait a minute. So in the research, it certainly supports exactly what all of you shared. Lack of time is one of the biggest reported concerns of providers in the primary care setting. And then we know that this will often lead to decreased screenings as well as limited time being able to share results and moving into what could be concerns or plans. Sometimes providers will also be concerned about lack of education. There has been noted to be some lack of education in nursing school as well as in medical school, focusing on these diagnoses. So depending on where the individual received their education, they might not have had a lot of background knowledge as well as interaction with families with an autistic individual. Less confidence. So a lot of providers report that they don't feel as confident because again, they feel so limited in time and education that they just don't know where to go. And then lack of resources. So just trying to figure out what to do, how to do it can be very difficult. And it also can be extremely time consuming. So maximizing time. So different places have different things. And one of the uh, resources that I reviewed suggested almost like a 10-minute quick and dirty. And again, we now know this really isn't possible because everyone goes down these stories and they want to tell you what's happening in more detail in their household. But the biggest thing is trying to maximize as much time before the visit as possible. So if you're able to send out screening tools through a portal or through a Chattis or through like a secure email and having the families fill this out ahead of time so that you're able to review the developmental history and look for any red flags or, just put possible indicators before they're coming in that you want to discuss. And then you can also have an individual in your at your office, or you yourself can work on preparing referrals or having a list already handy. At the end, we're going to provide you with a lot of resources. So hopefully you'll be able to piggyback and add that on or use that as a basis. But there are a lot of parent-friendly handouts that do exist and websites. So they will be given to you at the end of this. So hopefully that will help speed up some of that. And then during the visit, really just trying to focus on one concern at a time. So focus on X concern, then asking the more focused questions about it. What behaviors are worrying you? When did you first notice this? And then, of course, sharing the same observations you're seeing. So I also notice that little Susie is not making eye contact when I say her name and isn't responding when I say her name. And these are certainly things that we want to look further into. And I agree, you are doing the right thing by bringing this up. And then recommending next steps. So the biggest piece I take home is yes, we definitely need to have some sort of diagnosis in place, but knowing that we can try to utilize a lot of referrals, interventions early on, especially early intervention, as well as maybe having just one or two resources on hand that we can share with family members. Also delegating staff and using team support. So if you have an office where you have a staff member who's really interested in taking this on, maybe having them follow up or check in with the family a week later to see how things are going. And then maybe consider, okay, yes, what if the family is not receptive? So maybe try again to bring them back. Keep utilizing these screening tools to say, here is where we expect Susie to be. Unfortunately, Susie, or didn't even say unfortunately, this is where we expect Susie to be. Compared to other children, she is not at that point on their screening tool. And this is where we expect her to be. These are the services we want to utilize to give her the support to start being able to express herself more. The end. And so maybe also giving them time to chew on it and think about it, because sometimes families just need that moment to settle in and really process what you've just shared with them, because that can be pretty devastating at the time for them. And then screenings. So screenings are what we typically try to utilize in the office, and they're still highly recommended. The American Academy of Pediatric recommends them. They recommend a developmental screening tool at 9, 18, and 24 months. However, Maryland Healthy Kids recommends it at 9, 12, 15, 18, 24, and 30 months, which is really helpful. And we usually use the ages and stages or the PEDS developmental screening. For autism screenings, it's recommended at 18 and 24, and then the Maryland Healthy Kids recommends it at an additional 30 month. And often we use the MCHAT RF for our autism level 1 screenings. MCHAT does have a 60% false negative rate and will often not be able to differentiate developmental delays from autism specifically. So it can be a little confusing for family members. And on top of that, the I don't know if you've experienced it in your practice, but sometimes I'll have family members, even if I'm verbally doing the MChat with them and observing, they will often, I think, give me the answer they think I should be hearing or they think I want to hear. And what I'm observing is something completely different than what they're answering. And so that can be very difficult to discern in terms of maybe they are actually doing what the parents report at home and they're doing something different here in the office, but it still can be very confusing. And this flowchart I know is very small, the wording is very tiny. And it really is talking about if you have someone who screens positive with an MChat, that they definitely immediate action is recommended and they should be further evaluated for autism. And then if they screen negative and there's no concerns, then great. If they screen negative and there are concerns, then certainly following up, maybe having them come back. The recommendation on this screening chart by the CDC is to follow back up with the next well child visit. But I don't know about the rest of you, but I feel like there's a lot of time that passes between the 18, 24, 30, and 36-month well child checks. And so, and especially when we're looking at the toddler years, 6 months, you know, again, the little child could not be talking at the 24 months and then have a language explosion at 27 months and we would never, or not, and we would never know. And so I feel like often trying to bring them back in a little sooner, and depending on your office and how you're set up and what your availability is, it would certainly be ideal if you could bring them in a sooner for a developmental follow-up. And then another chart that was put out by American Academy of Pediatrics looks at what to do and how to do it and how to go about it. But the key point about this is that even if you have concerns or in the family has concerns and you're going down the path of screening for autism and evaluating and diagnosing, that all the other pieces can be done at the same time. They can be referred for occupational therapy. They can be encouraged to start Head Start. They can go and do swim lessons. And so there's definitely a lot of other options out there, but I often feel like family members feel like they have to have the diagnosis and tangibly in place before they can move on to doing things. And we all know that that's not the case. And so I try not to take a whole lot from the CDC because as we know, it's changing right now. But the CDC does have possible indicators. And so if your family member does have is a individual who really could use tangible items, these possible indicators are there, and sometimes they can help support what you're trying to share to the family members. And then I'm going to pass it over to Dr. Gerard for the next few slides.
Thank you. I'm going to talk a little bit about what the diagnostic components of an autism evaluation include. And this is based on, of course, best practices, but also for us in the state of Maryland, for Medicaid to cover ABA services and other supports for children. The diagnosis has to be made by a qualified provider and then also have certain components. So one is having a thorough developmental history, and then some sort of structured observation, that can better elicit some of those autistic traits or some of those symptoms of autism. And this obviously is something that can be very timely, and I know a limitation in practice as well as with reimbursement rates. So often, we're referring for full psychological evaluations. Some other pieces that can be really helpful, especially when the presentation of autism isn't super clear, are looking at adaptive functioning, cognitive skills, and then also looking at speech or language in terms of determining if there's also a language disorder or delay in our younger children. And then, of course, also wanting to rule out any hearing concerns, especially when there are those speech delays initially, to make sure that it's not related to hearing. So while these last few pieces are not required to make the autism diagnosis, they can be really helpful in teasing apart what is going on for the child and what some of these symptoms are related to, as well as to determine the level of autism, and therefore determine the level of support needs for the child. Next slide, please. There are two different types of diagnoses. So medical diagnoses are what we all would be making. So what I do in my practice as a psychologist, if you are doing any diagnosing in your pediatric practices, that's considered a medical diagnosis. This is what allows children to receive services like ABA therapy that would then be covered by their insurance, and any other kind of like SSI benefits, autism waiver, list services, things like that. There is a difference between that and the educational diagnosis of autism, which allows a child access to an IEP coded for autism, and then all of the supports that the school system can then provide to the child. And this is an important differentiation, because sometimes children will come in and parents will say, oh, the school diagnosed them with autism, and then, wanting to go ahead and get started on, ABA therapy, but they actually need a medical diagnosis before they can do that. And schools will oftentimes accept the medical diagnosis in informing special education services, but it's not always the case. There are times when they may want to do their own evaluation as well. So of course, there are a lot of benefits in being able to diagnose autism within the primary care setting. As we know, that's where we are most likely to see the highest level of children. If they're going to go to any type of an appointment, it's going to be, sick visits, well-child visits. But it's really important to not only have an understanding of what the diagnostic elements are for autism, but also what are the requirements for that diagnosis to actually serve its purpose in terms of getting additional services for the child, as well as just the referrals and recommendations and understanding what's in your area and what can be offered, and how to get set up with Child Find or infants and toddlers, depending on the age of the child. With ultimately the goal being, as you all are well aware, if anyone wants to use insurance to get a diagnostic evaluation of autism, the wait times can be astronomical. And meanwhile, we know early intervention is key, and the clock is often ticking trying to get these diagnoses. So, when it can be completed by a trusted primary care physician that the family already has rapport with in the practice, of course, can really help increase access across all patients, especially when there are some of those socioeconomic barriers to getting treatment elsewhere. And I'll turn it back over to Krista.
Thank you. So there's lots of things we're going to be sharing with you, and one of them is Children's National actually has a really wonderful toolkit, and if any of you have utilized it, that's fantastic. If you haven't, we have included it in the resources that we will be sharing with you. But they have a really nice triage system to sort of help you decide, could I evaluate in my primary care setting or not? And the green individual would be someone that when you walk by them in the waiting room, you're like, hey, there's something about this child that makes me think there might be some autistic tendencies. They're very consistent. They're younger. You might see them spinning in the waiting room, maybe hand flapping. They might be covering their ears if the sound is too loud. They're just very well might have very classic symptoms that we have all seen present. And then those would be the ones you could consider evaluating in your office without waiting for a specialist setting. The maybes are a little bit more difficult, and they're the ones that the traits are maybe a little bit more subtle. You're kind of waxing and waiting and not sure. There could be an intellectual disability or maybe not. The child might be even older. And these are your children you want to refer for your comprehensive autism assessment. And then there are the individuals that could be labeled with a red color. And they're a little bit more complicated, or even maybe the older child individuals, so you're not sure what's going on. Again, I think of this of this child as someone. I recently had a family who had moved here from Guatemala, and the family had not had any services before, and there was some talk about whether the child was deaf or not, and the family just wasn't sure what was going on. At the time he was already 6 and should be going to kindergarten. He played well with his siblings, but there was definitely some subtle traits, and he would certainly get upset, but he also had just moved, and there was just a lot of layers. And so he's actually receiving services through the school system currently, and has been accelerating and thriving extremely well. And they're still not very clear whether there could be an autism diagnosis there or not. And the family doesn't want to go seek further evaluation yet. They want to see what he does in the school system first for the first year before going down that path, which, of course, we have to support what the family wants. And then, so for education, again, for all of us as providers, there's a lot of options, and it could be, like I said, there was a big net, and we went smaller and smaller, smaller. But BHIPP has a wonderful library and a lot of it on their website, and they just have a wonderful resource list. And they also have echo programming, and echo programming isn't specific just to BHIPP, but BHIPP's echo program is wonderful. And if you haven't attended it, I have, and I love it. This utilizes a case-based study approach, and they also utilize didactic education as well. And it gives the participants a chance to discuss the case as well as learn something from the didactic portion at the end from an expert. But there are also, and again, this has provided you links to go to other echo programming, and some of them are very autism specific. I think KKI has, 2 or 3 echo programs. The University of New Mexico, where it originated, has quite a few. And so it's a very valuable resource. We've also provided a list of podcasts. So if you're someone who likes to learn while you're doing other things, we have a list of podcasts that I believe I vouched all of them. Hopefully, I've listened to as much as I could to make sure that they were reputable, as well as ones for family members. So there's two different lists that you can share for yourself and for others. And then there's also other organizations that provide a lot of educational opportunities and seminars. And Vanderbilt Kennedy Center has a huge list of free educational opportunities. And I did a lot of those, and they were very valuable. And so those are also going to be given to you at the end for you to be able to access. And so then moving from education into confidence, so we have to remember that when we listen to a child's parent, that 80% of their developmental concerns are usually correct, and they're usually associated with a developmental delay or a risk. And so at any particular time, we should consider autism if a parent mentions a concern about language delay, eye contact, social skills, hearing problems, or repetitive behaviors. So in doing so, we want to keep our ears out for those key phrases. We want to set the stage for a successful conversation, and we want to really be non-judgmental, which I believe in pediatrics, we all do that very well. But we also want to be as supportive as we can. But again, we all know it's a time crunch. And so we want to, give them the tools that we can and keep following up. And then we want to keep referring and focusing on the milestones that we know they have successfully completed, and maybe the ones we expect them to have already completed. And so using terms like maybe let's rule out, let's further evaluate, sometimes that's a little bit of a gentler phrasing that families tend to appreciate a little bit more rather than, I know this child's autistic and you definitely need to be doing something about it. That does not come over very well. And the phrasing typically puts up that wall. And then, we don't want to dismiss the parent either, and we also don't want to scare the parent. And so we want to keep it as positive as possible. And certainly, we've learned very early on in pediatrics, you don't want to compare one child to another. Now, it's very difficult when utilizing the screening tools because, again, you don't want to say, and again, I was trying not to say it earlier, you don't want to say, well, this is where all the other children are, but we should be utilizing this tool as this is where we expect your child to be doing, and keep it just as simple as that. And so how to create a successful environment. So again, there's a big rabbit hole I went down and I went through looked at a lot of pediatric practice websites in Maryland and saw what they had to offer. And I need to give a nice shout out to the Pediatric Center in Frederick because they have a great page on their website referencing the American Academy of Pediatric Guide for going to the doctor. And they have a lot of resources there already listed for the family members. But you can start out when scheduling the appointment. So maybe giving some of your staff a little bit of an in-service on when the family calls, maybe asking a few key questions. Does the child have a developmental or behavioral diagnosis? Do they have any special communication needs? Do they have difficulty with changes in their routine, maybe going to the dentist or maybe getting their hair cut or any other similar appointment, like going to their doctor's office? And if they say yes, then that should cue us to try to build in a little bit of extra cushion time. And if your practice allows for that cushion, great. If not, maybe kind of sacrificing your lunch hour a little bit, or maybe putting them at the end of the day, just so that you're not impacting other patients coming in as well. And then maybe putting notes in the chart, flagging the chart so that every time this patient comes in that how to be successful. You can also utilize staff members, not just for questionnaires ahead of time, but asking the family how to make the visit successful. There's great tools, which we're also going to share with you. There's the Autism Care Questionnaire developed by Mass General and the Autism Friendly Questionnaire developed by Rady Children's. And it's a simple one-pager asking parents, what could be potential triggers or what could be upsetting to the child versus what the child enjoys. And that really helps you guide on how to make the visit very successful. Also finding out how to calm the child, that can be very important because again, sometimes we see an escalation and having the parent know what to do and cueing off the parent because again, they're the expert is going to be very impactful and important. There's a lot of social stories out there, and so encouraging role play and having parents know how to access these social stories. And then what the social story does is it gives a nice picture or a video and with a very simplistic, straightforward couple sentence story for each frame so that the child will know what to expect when going. It even goes down to how to get, today I'm going to get my blood drawn at the office and or today I'm going to get a vaccine. And so it's very specific. Autism Speaks has a virtual visual support toolkit, but there are many others, and we've linked those all for you as well. Some offices, as I've looked at, actually have created their own social stories or done like little videos of the office about, hey, this is when you first come in, this is who you see, or this is the desk you see, and this is where you go next. And that's very helpful and impactful for families as well. Maybe sensory considerations, so dimming the lights or having a room that's specific that the volume is not as loud in, and maybe consider doing the vital signs at the end because often the blood pressure can be very sensory challenging for autistic individuals. Having sensory toys or objects in the office for the patient to be able to utilize. And then encouraging family members to bring items in from home. That is also helpful. Maybe try to minimize how long they're in the waiting area. And again, starting small and having small wins. So if they're very sensitive with their ears, maybe not doing a full otoscopic evaluation if possible. Maybe start by just gently touching the ear, maybe tugging on it, maybe letting them manipulate and play with the otoscope and seeing how, how it works. And then letting them explore it and using, again, very simple language, you know, right arm, squeeze my hand. It's very straightforward, simplistic commands is very helpful. Some families will utilize a checklist and cross off as things are completed so the child knows things are done. And then considering the safety of the room. So sometimes we have these nice office areas that have a lot of things that could be unsafe if an individual grabbed them or accidentally bumped themselves into it. And so just looking around in your office and saying, could someone accidentally injure themselves by pulling something down or throwing it? And then praise and positive reinforcement. Years ago, one of my campers loved pipe cleaners, and I could just easily pass a pipe cleaner every time they did something wonderful. And so again, maybe finding out ahead of time, what does this child love? And if you don't have that in your office, asking the family to please bring it in, so then they're rewarded at the end of the visit. Oops, sorry. And so discussing concerns, Vanderbilt Kennedy also has a nice acronym. And it's called ASD Pattern Check-In. So again, if you need to kind of have a simple way to think things through, A is just a line. Yes, I see that little Johnny also has difficulty expressing himself. But then S is strength. So you want to focus on, but even though Johnny's having difficulty expressing himself, gosh, he put together that puzzle really wonderfully, or I've never seen a child jump like that. That's fantastic. And then comparing the differences, so we expect Johnny to be speaking at 200 words, typically clearly. Right now he's speaking only 6, and then bringing it together. So then with the expressive language delay, with the decreased eye contact that I'm seeing, with the lack of response to his name, these point towards a possible diagnosis of autism, and I would like to further, evaluate or investigate it. Or what are your thoughts about this? Or what do you know about autism? Sometimes these can be indicators of autism. And just kind of having the family kind of check in, seeing how they're processing and where to go from there. So resources for your office. We put together a lot of them. There's, again, the questionnaires that you can utilize. There's some documentation support that's been included. So, having handouts ahead of time, which, again, we've put those together, or access to a lot of those. The social stories, like I mentioned, empowering staff, because I don't know about you, but I've definitely worked with individuals who really want to do more in the office and want to take the lead. And I think that that's a great, definitely a great working ethic and a great way to really be impactful as a team member. And so maybe having them help as well. There's also there's some videos and some, we'll call them certifications, that an office or a business can do to be designated as a sensory sensitive office. So, and again, we'll talk a little bit more into that in a second, but that's also something that could be helpful for the staff members. Again, maybe having a sensory expert, so someone who has maybe access to all the sensory items and keeps track of them and has them out for the individuals, keeps a room that's a little bit more sensory sensitive for specific families, and that would be very helpful for your practice. So again, early intervention, we love it. We will utilize it. They're amazing. Again, under 36 months is infants and toddlers here in the state of Maryland. Over 36 months is child fine, and utilizing it in the school systems. Again, if you don't have access to these, again, we have access to those provided in our resource list. And again, helping the families navigate, because I don't know about you, but I've had family members who are aware that their child is most likely autistic, but their biggest concerns is food insecurity or housing insecurity. And so they can't even call or even make the appointment because they have transportation issues and can't seem to figure things out. And so we really need to provide those baseline supports as best we can first sometimes, as we weave in the more targeted supports with speech and language, maybe Head Start, and then getting the diagnosis and having the specific ABA programming or crisis intervention, and sometimes hospitalization is important for a patient. So community resources, and again, there's a lot of navigation, a lot of things, and we're going to give you a whole lot. But there are search engines at Pathfinders for Autism, Autism Speaks, and Autism Society of Maryland. However, when I was accessing these and double checking and looking, quite a few businesses may have closed or their website might not be up to date. And so what we try to do is really provide you, as of, I believe it was 1 month ago when it was finalized, key resources that were accessible and current. And so you will be receiving a list, basically by county if needed, of audiologists, occupational therapists, physical therapists, speech and language pathologists, salons and barbershops, community venues, Head Starts and daycares, dentists, camps, music therapy, equine therapy, and caregiver and family resources. So many of these I've grouped by region or county or city. Also, in doing so with, like, let's say the dentist in particular, there have been links to the social stories for dentists as well for the family members and how to have a successful dentist visit. The other pieces are like for salons and barbershops, there are the resource. If you have a family member who loves to do hair and they want to be more sensory sensitive, there are links on how to make your hair salon more or your barbershop more sensory sensitive. And so those are also included because, again, this isn't not just for us as providers and the families. I'm sure all of us have touch points of somebody who might say, gosh, I really would want my business to know what to do when someone comes in and I want to be able to help and be more sensitive. Sure, then here you go. This is for you. In terms of caregiver family resources, there's support groups I've listed in there. There is a bunch of education, and that's brought down from podcasts to small little venues and vignettes. And it also details exactly what they've offered and what specifically they did. They highlight in there, whether it's toilet training versus sleep, but that's all there for you. But I did do separately on this slide safety resources because sometimes that can be very challenging for families and that could be one of their first concerns. And the National Autism Association has their big red safety box, and families can get that for free. So as soon as they go on the website, they can just go in and ask for one, and one will be sent to their home. Skechers actually has a compartment that you can put an air tag in that's meant for lost shoes, but similar in nature, the child can't feel the air tag in there. And if they are someone who tends to elope, but while wearing their shoes, of course, then that might come in handy in terms of being able to locate the individual. Alert Me bands, those have a GPS and emergency calling. The buckle balls is a little device that you can put over a buckle of a car seat or the lap band so that someone can't unbuckle themselves freely while the car is moving. But it's also safe enough that in case of an accident, they can be quickly undone. The toddler, If I Need Help, has a lot of safety products for people with autism as well as even people with like Alzheimer's. The toddler monitor is a door alarm that gets placed above at the top of the bedroom door. So when the door opens and closes, an alarm sets off so you would know if the child's leaving somewhere in the middle of the night. Autism Speaks has a safety kit with checklists, also has sample letters that you could share with neighbors if your child does tend to elope and know how to have that conversation. Swim Angelfish has a water safety toolkit, as well as Autism Speaks has a lot of adaptive swim resources on their website. And then IEP support. So unfortunately, there is a bit of a shortage financially and in terms of employment for one-to-one caregivers in the school setting. So when family members are putting together IEP, stressing the importance of having an elopement plan included in that IEP write-up is very impactful. And then comorbidities, there's a lot of stuff on there. I'm just going to quickly highlight that we've included a lot of resources, but in particular, BHIPP has a lot of very valuable information if there's a concern for behavior or aggression. They have a lot on their website, but we can always call their hotline and access someone who can be helpful. Even if there's psychopharmacology, they can offer support with that. And I have utilized them quite a few times, and hands down, every time it's been very successful. One key point to make as I'm going through when I went through all of these is with like seizures, the recommendation is still not to do a screening EEG if the child is asymptomatic and has never had a seizure. But otherwise, there is an increased risk of seizures in children, in autistic children, roughly about 7 to 23% in the different community samples that are out there. GI symptoms, we know there's a whole host of them out there as well. And we've given you links on like toilet training as well as some other key helpful resources. Autistic children are more likely to be obese, especially if they are manically managed with an antipsychotic. So again, encouraging activity, the dental concerns. And so one of the key pieces to remember is if a child comes in and don't express themselves well and the parents aren't sure what's going on and their behavior's not how it typically is, make sure we look in the mouth because sometimes there could be a dental carie or an abscess or even a cracked tooth. Because I've experienced a lot of children who will teeth grind, and so that can be a very big concern. There's also, again, with pica, we want to make sure we're screening for lead exposure, depending on what they're putting in their mouths. And then sleep, there's a huge list of sleep resources, but the nicest one I noticed was by the American Academy of Neurology, and they have a practice guideline on sleep in autistic children and adolescents, and that's also been included for you. And then we know that 50% of autistic children have ADHD, and 50% also have anxiety. And so certainly making sure that we're screening for those and paying attention to those concerns as well. And again, that's all we've provided all that for you. So the specific provider resources, you will receive those as well. That's going to be separate from the community resources that will be handed to you. And again, there's going to be a little bit of a synopsis, a little bit of a write-up about what each are and what they will be providing so that you can look and see what would be helpful or impactful for you. So the continuing education will exist in there. There's the documentation support, and there's a lot of good toolkits out there. The American Academy of Pediatrics has one, but it is not free. And then, of course, there's other certifications you can do. And the last thing I'm just going to touch really quickly on is the level 2 screeners. You can get certified as a level 2 screener if you're not already. And the Kennedy Krieger has the Rita T screening. I'm in the process of doing this myself. The training can sometimes be free, but sometimes it actually costs $200 if you do their online screening. It is very easy to train and learn. What I've experienced so far has been very wonderful. The really cool thing about this level 2 screener is it helps you differentiate well between toddlers who have ASD and toddlers who do not. And so it can be used on children who are nonverbal and non-English speaking. So you don't have to have a verbal child to administer this screener. And that could be done, and that can often be enough of a developmental screening for the insurance to start providing to acknowledge the diagnosis of autism. There's the stat level 2 screener as well. It's more expensive, but it does exist, and a lot of people do utilize this. And then there is quickly a research opportunity through Kennedy Krieger. They are piloting a video development, an online developmental screener. I have seen it and witnessed and piloted it. It is very interesting. It's ideally going to take the place of the ASQ. And so family members watch videos and then answer developmental screening questions. The nice thing about it is at the end of them doing this, and it takes about 20 minutes in total, and you can ask your family members to do this, even if you have developmental concerns or don't. They will receive they will meet with a specialist, a research specialist who's also a developmental expert, and they will go through what they've answered. And, even if there's concerns, or not concerns, they will go through it. And if there is concerns, this actually helps fast track them into the Kennedy Krieger system for formal evaluation. So often this is a nice little springboard into the Kennedy Krieger platform. And again, we will have the flyer and all this information for you as well. And then I'm going to skip that and then leave for questions.
Thank you for that wonderful presentation, Krista and Antonia. At this time, we've asked people to put their questions in the chat and we can follow up with that. I already have one question. So for specific resources such as autism waiver services, a patient has to have MA. I'm not sure if how do we assist a family who has private insurance? Will they be able to apply for MA services for patient due to ASD needs? Antonia or Krista?
I was looking for where the question was. So in terms of like the medical diagnosis with commercial insurance versus medical assistance, did I understand that correctly?
I believe it's whether or
Yes.
not they can access, I think it's whether they can access the autism waiver even if they have commercial insurance.
No, it's only for medical assistance. They have to qualify based on like certain financial hardships as well.
A lot of thank yous for putting together the resource toolkit.
Hopefully it'll be valuable. And feel free to please let us know whether there's a resource I'm not aware of. Again, the bucket was large, and again, try to make it more tangible because I feel like as someone who also works in the office, you're trying your best and you're like, oh my gosh, you live all the way in Frederick. Let me see what I can find in Frederick, for you. And you're like scrambling and trying to, quickly Google search. And so really the goal was to try to give us as much as we can without it being as much of a scramble, if that makes sense.
Oh, here's a question. Someone said, in the resources, I have seen a slide about a barber and a dentist. Do we have to communicate with them to accommodate the children, the ASD, like to reach out to these locations ahead of time?
No, the ones I looked at and looked into are all comfortable with children with who are neurodivergent. But if the family member would like to give the when they make the appointment, give a heads up, I'm sure that would be very beneficial.
Okay. Oh, I see another question. Thoughts on office screening for kids older than 3 years old? We see mostly uninsured, new immigrants who have not had prior screening or diagnosis. They often do not want to access county services or have a hard time doing so.
Dr. Gerard, I don't know about your experience, but I know from the pediatric primary care office, there's really not a lot there's a few screening tools, but there's not a lot that we can do in our office without referring out. I don't know if you've experienced any as well.
Uh, Sorry, trying to find my unmute button. Let's see, Beth. So there's, well, in terms of getting a formal diagnosis, it depends obviously on insurance. With Medicaid, KKI obviously is a common referral source with very long wait lists, same with Mount Washington, and then also here at the University of Maryland. So a level 2 screener alone cannot diagnose autism. Any screener, even like the ADOS that we use in our autism evaluations alone cannot qualify to diagnose autism. So it does have to be done in tandem with a full developmental, social, emotional, behavioral background interview at the very least. So there are trainings for different screeners like the RIDA-T, and that is through KKI. That can be helpful as a screening tool that's a little bit more intensive than an MCHAT, but then it's a required year-long training to actually be able to diagnose autism on top of that.
I think they were also wanting to know what can we do for the older kids who are older than toddler and childhood, more of the school age range.
That's going to be a lot. Well, not a lot harder. I mean, there are screeners like the CARs and things like that that can be utilized. But again, it also has to be in the context of, being trained in diagnosing autism and doing that developmental history as well. But there are screeners for, the whole age range, including into adulthood. And Dr. Masood, I see your next question. ABA companies denying diagnoses by NPs and PAs. It seems like for NPs, they shouldn't be denying the diagnosis as long as it has the required components. So I know there were some questions that come up about like CRNPs versus NPs. And so it seems like there's something that needs to be kind of switched in terms of submitting those referrals, but they shouldn't be denied. So qualified diagnosers include NPs, developmental pediatricians, psychologists, neuropsychologists, I think neurologists, and psychiatrists. So all of those would be qualified.
To circle back to the childhood one too, the link we provided for the Vanderbilt Kennedy Center that does the stat level training also has access to the CARS and a couple other older. I think they do the ADOS as well. So you can do their online training, get formally trained as for those screening tools. So some people find that's helpful for the older children.
And there was one, I think this is the last question we have time for. Can you share the resources for older children? I think that might be in the list, but if you could just let me know, and we can make sure we can centralize that.
Yeah, I believe that it's so for the screeners, it's the Vanderbilt Kennedy one, and I can't remember if I wrote that it's for the young and old, but it's for the same ones who have the stat level screening that you can do, and that's going to be in the provider list. For the activities, like I write down which movie theaters have sensory days as well as like specific camps and so forth. So any, there's included when the zoos go have certain have great hours. So it's all listed out there. So these don't have to be just toddlers. This can be the 8, 9, 10-year-olds who could certainly be doing some social experiences that don't have to require a diagnosis, but also doesn't have an age limit as well.
Okay. Great. Thank you so much for sharing so many of these resources and all of your knowledge today. Thank you for the wonderful presentation from both of you, and to our participants for asking such great questions. The recording for today's session, the PowerPoint slides, and the list of all the related resources will be available on our website next week in the training library. Also, we might email those out next week if they need that specifically. We'll send CME and CEU certificates to the participants by Friday, November 7th. Please remember to take the survey as you exit, as this is required if you would like to receive CME CEU certificates. Stay tuned for future BHIPP trainings by following us on social media. And thank you so much again. I hope you all have a wonderful rest of your day. Great.
Thank you. Take care.
Thank you.
Thank you so much. Thank you, Krista. That was wonderful.
Oh, thank you so much, Grace and Bethany. I really appreciate your support because I definitely could not have done it without you, for sure.
Oh, no, you did wonderful. It was great. So I'll follow up if I have any questions about the slides or anything, but thank you again and have a great rest of your day.
Great. Thank you too. Thank you both.
Bye.
Bye.